All aboard! Have any of you noticed, you were dreaming through the night this last week. Did you notice dreams? So the more you're going to be aware of the fact that you're dreaming means that's a great thing, because it means you've come to the end of a sleep cycle. You're in the light phase and you're about to catch the next train. So that's fantastic. A little review. This is our course curriculum. We're coming to the end. The trains. This is a quick review. Each sleep cycle is like a train. It has an engine, deep sleep cabooses, or deep sleep cars, a light sleep car, and a caboose. And that's that stage when you're sleeping. Have you noticed any difference in your sleep patterns since last week? Has this information been helpful to you? So it's helpful just to know what it is. We've had conversations that people are dreaming more. That's great. The more you dream, the more sleep cycles you're completing, rather than waking up in the middle of a cycle and not being rested. A little note about what we were like when we were hunter-gatherers. We used to go to bed when the sun went down, and now we block out our melatonin because we let white light into our eyes. If you can find a way to either switch off the lights, use a candle, or avoid using computers and laptops and cell phones, or put a blue blocker on, you'll find it makes a difference. We gave you some sleep strategies. You might have gone through them one by one. Take your time, read them carefully.
Okay, so stress. Anybody relate to stress? Somebody mentioned the Columbia Pain Center. I did my practicum for my counseling degree at the Columbia Pain Center. And my major paper was on depression. And it was basically what comes first, the chicken or the egg. Is it depression that causes pain, or is pain causing depression? Or, what's the relationship there? And I don't think I ever really came out with a definitive answer. But I think stress begs a very similar question. Certainly, our lives are stressful, and I'm sure you've noticed that when you're dealing with a lot of stress, it's harder to deal with your pain, right? And sometimes it feels like your pain is worse. And yet sometimes I'm sure you wonder, is it stress that's causing my pain? Is it stress that's really triggering the pain, or is it the pain that's causing stress? So that's one of the questions that people sometimes ask. But certainly stress is one of the big factors that factor into our experience of pain, for sure. So something I'd like you to consider is, which would you say is actually more accurate? Stress is harmful and should be avoided, reduced, or at the very least managed? Or stress is helpful and it should be accepted, utilized, and embraced? Pardon? Which kind of stress? Yeah, there's many different kinds of stress, and we're going to talk about that for sure. Any other comments about that? Neither? Both. Okay. So a book I recommend, and we talked about her sister. These are twins, Jane and Kelly McGonigal. Jane was the one that talked about when you do stuff, it's helpful. Kelly talks about the upside of stress. And she talks about, for about 10 years in her career, she talked about stress very negatively and tried to teach people how to deal with, manage, and reduce stress. And then she found some very shocking scientific findings. What she discovered is that a high level of stress increases the risk of dying by 43%. However, it only applies to people who believe that stress is harmful. Interesting, right? So high levels of stress result in the lowest risk of death when people do not believe that stress is harmful. And it's even lower than people who experience low levels of stress. So this is bearing out with scientific data. So here we are. We're back to CBT again. We're back to that cognitive choice. And really what it is here is often it's just choosing what you want to focus, where you want to focus. So there's something called the fight or flight response. But what Kelly likes to talk about is something called the challenge response. And so in the fight or flight response, first of all, you believe that your survival is on the line. So a saber-toothed tiger is chasing you, or there's something that's literally threatening your life. And when that happens, you have a certain ratio of adrenaline cortisol. Usually you have fear. Well, almost, I'm sure always you have fear. It mobilizes energy, so it makes you alert, so that you're ready to act. This is your sympathetic nervous system, so your heart rate goes up, your muscles in your brain are getting blood pumped to them, so they're more efficient, they're stronger, and you're geared, you're poised to be able to do something, to act, to take care of yourself. So this is fight or flight, either fight or run away. The challenge response is when your perception, you believe that there's stress, but it's not as threatening. It's less threatening. So you have adrenaline and cortisol as well, but they're at a slightly different ratio. You're focused, but you're not necessarily fearful. There's increased energy to perform under pressure. The stressful experience is seen as beneficial, not harmful. And there's a sense of increased confidence, enhanced concentration. It's kind of sort of the peak performance. You think of maybe peak athletes, people like that. So interesting, we came up with both. Is it either or? Is it both and? And I think that, again, it's probably a balance between both, and it sort of depends where the focus is and what our belief system is about stress. One thing about stress is there will always be stress. So it is about either managing it or at the same time maybe looking at what your beliefs are about it. So what happens if we decide to think differently about stress? Can you imagine stress to be beneficial? Yes? When do you imagine it being beneficial? Right? Pro golf, for sure. More alert? Yeah. So you remember that feeling of that challenge, but it's stress. Yeah. But if you think about, and what we've talked about here, is stress and meaning. If it has a meaning for you, being a pro golfer, there's meaning there. Make life and death. There's meaning. Life is meaning. So a meaningful life. And what brings meaning to your life often is also bringing stress. So, for example, things that make the struggle worthwhile, make the stress worthwhile. Raising a family. I think it's Kabat-Zinn who talks about the full catastrophe of life, right? All of it. But it's worth it because, children are stressful, but they're wonderful, but they're all those things. Meaningful work, what you talked about, both of you talked about. A meaningful cause. That passion that people have when they have something that it's very meaningful. So stress and meaning, if you focus on the values, on the needs, remember we talked about putting a frame around this course being needs, and needs are sort of the bedrock. And so it's thinking about what's important to you, what's meaningful to you. And often when that's kind of the priority for you, you approach stress. You're much more likely to approach stress as a challenge. You get to see that there's meaning in adversity. And it brings us to that concept of resilience. Resilience is defined as a capacity to recover quickly from difficulties. It's kind of like a toughness. It's an ability to adapt to stress and adversity. And it's seen as a process. It's not a trait. It's not some people are resilient and some people are not, and it's just genetic or whatever. It's actually a process that can be learned and it can be developed by anyone. So that's a really helpful piece of information to understand. is that you might see someone in your world who seems more resilient than you are. It's not necessarily because they have anything that you don't have. They've learned how to be that way. And you can learn how to be that way too. This guy, Martin Seligman, is a positive psychologist, and he did a lot of work around building resilience. And there was a guy in the U.S. military who phoned him up and asked him, he wanted him to work with soldiers coming back from combat, because between 20 and 25% of them were coming back with something called post-traumatic stress disorder. And he wanted this person working on resilience to work with these soldiers. And he said, well, yes, I will do that. But I want you to know that where my focus is really going to be is not the 20 or 25% who came back with post-traumatic stress, but what about the 70 to 75% of the people that came back without it? What did they do? What did they bring to that situation that the other soldiers didn't? And that's basically the focus of his research. So next week we're going to talk a little bit about trauma. And trauma is certainly, it can be a result of physical injury, but what I'm going to be talking about is emotional stress, emotional trauma. And it's a continuum right up to post-traumatic stress disorder. And what I want to just bring to your attention, I don't know if you remember back when we talked about the sheet, the feedback sheet that we worked with. We talked about Daniel Siegel's hand model of the brain. And remember that the palm was your reptilian, your primordial fight-or-flight brain, and then the thumb folded over is your emotional brain, and then folded over that is your cerebral cortex, or your thinking brain, your cognitive brain. And so CBT, we've been talking about, is cognitive. So with CBT and almost everything we've been talking about so far has been talking about your thinking brain, your cognitive brain, and how it actually interacts with your emotional brain. And of course, your emotional brain also interacts with your thinking brain, so there's interaction back and forth. Something that we haven't really talked about as much, it's not going in there, is the midbrain. So we talked about that this is the palm, this is the reptilian primordial brain. And it actually has effects both on the thinking brain and the emotional brain, and vice versa. And so we're going to touch a little bit next week in our final class on something called somatic experiencing. And what that is something that was designed and sort of brought into being by somebody named Peter Levine. And he looks at people and really kind of notices that we are animals. We have animal instinct. And that part of us affects us, whether we want to be aware of it or not. And he really, he's developed an amazing technique to transform trauma without having to engage the thinking brain and even necessarily the emotional brain. Because something that's become very, very clear to a lot of people in counseling, certainly to myself as a bereavement counselor, is that sometimes the cognitive thinking and talking about emotional trauma is actually not helpful at all. It actually re-traumatizes people. And so what now we're learning is there's ways to deal with that kind of trauma without going to that cognitive place. And so it's just another sort of adjunct. It's another thing that adds on that can be really, really helpful. And what I find, I'm actually going to be next week going to a trauma conference, because not that I want to be a trauma counselor, because I think it takes years to be a really good trauma counselor. But as a bereavement counselor, I need to be able to recognize when someone needs that. And I'm basically making it my business to find out who are the good trauma counselors in town, so I know where to send people when they go into a freeze and basically they're at risk to be re-traumatized. So that's something that we're not going to go into in depth, but something we're going to talk a little bit about next week.
You know that when we're talking about exercise according to this little grid, we're coming to the end of our program, but when we started putting this course together a year and a half ago, I really didn't put much attention on the exercise piece because I hadn't really researched the link between exercise and CBT. So the more I prepared this talk, the more I realized how relevant it is for this group. And 2 weeks ago, we asked some of you to hand in a questionnaire. We got 31 back, and 20 of you are doing some form of exercise. That's fantastic. Fantastic. And some may be doing exercise but didn't mention it. So I can't tell you how important this part of the talk is with respect to this global process that we've been talking about. And it's a big challenge. And we're going to go right back to pain patients' beliefs about exercise. Now, I'm not going to ask you to point them, but they're this group here. Let's see if it resonates with some of you. It helps. I sleep better. It improves my mood. I feel better. I have to push myself. It's easier with a friend. Afterwards, I'm glad I did. Are those belief systems that some of you can relate to? Let's look at this other one. These may be belief systems you may want to look at as well. Didn't work last time I tried it. It makes my pain worse. I'm re-injuring myself. I just don't have the energy. It's overrated. It's not my thing. It doesn't help. I do too much and it hurts after. Can any of you relate to those thoughts? So it's entirely within all of our experiences that, in fact, we have all of these belief systems. We all have these belief systems. And these belief systems are the cognitive base around how we approach exercise. So there are three big topics that people talk about in the literature that have to do with the problems with exercise. One is deconditioning. We all know what that's like. When I was younger, I used to play rugby in the rugby season, and then we would be deconditioned all summer long, and then the first practice back would be awful, ache and groan and grumble. So we all understand what deconditioning is in the ordinary sense of the word, but for pain patients, it's a specific issue that you all can relate to. And then there's the boom or bust, and then there's the avoidance. Boom or bust is, I'm going to go to the gym now, and you go to the gym and you come back the next day and you just wiped yourself out because you did way too much, and that's it. I'm not going back to do that again. Been there, done that. And the other problem is avoidance. Avoidance and procrastination. I'm going to go to the gym tomorrow. I'm going to do my exercise on Thursday. I'm going to put it off a week. I do that also. I'm preparing this and saying, I'm preparing this for myself. So in the deconditioning, these are the thought processes that we go through that lead us to deconditioning. It makes my pain worse. I'm re-injuring myself. I don't have the energy. It's not my thing. Doesn't help. Not motivated. These are the thought processes that lead to the deconditioning cycle. And there's a lot written about the deconditioning cycle. The less you do, the stiffer you become, the slower your metabolic system, the slower it just circles around and around. So this is something we can all relate to, not only in a normal situation, but in the context of chronic pain. The second thing they talk about is the boom and bust. I've just described it to you a minute ago. Went to the gym, did too much. The other night I went over to visit my grandson, and he's got a rugby ball. He said, let's go and play rugby. So the next day I felt like I'd done too much. Rugby was something I did when I was younger. And it hurt afterwards. And then there's the whole process of avoidance. And you'll see we have our mindsets, our belief systems. Now, we all rotate through all of these mindsets all the time, all of us. And so these are the elements that have to do with decision-making. So it's patients' belief systems about exercise that govern whether or not we exercise and whether we don't. And I know, because I've seen so many pain patients over the years, that it's a huge challenge to exercise and to maintain exercise. And that's what we're going to try to talk about now. So let's Let's look first of all at what we know about exercise. What do we know about exercise? Here's a question for you. We'll take a 2-minute break and come back to the questions. Okay, so we've got some people who say no, and many of you who say yes. Well, the answer is, it does. There are a lot of articles in the literature that have reviewed all manners of pain and all manners of exercise, and the general consensus is that exercise therapy is beneficial in the treatment of chronic pain. And I've just given you one reference here: exercise, not to exercise, or how to exercise, applying the science to practice. So we're going to show what the science to practice transfer looks like. Here's another question for you. The answer is yes. The second question is, does CBT on its own decrease chronic pain? We've been talking about that right through this course, and the answer is yes, it does. But here's a third question. What happens if you actually combine CBT with exercise? There's a novel idea. What happens? Do you get the same benefit that you would by exercising without CBT or CBT without? More. Absolutely. You get what we call synergism. You get more than expected. You don't get 1 + 1, you get 3. And that's what this course is about in terms of trying to help you to see the value of looking at your belief systems around exercise. Now, here's another question for you. If you've got a pencil and a piece of paper, get ready to write it down. And if you don't have a pencil and a piece of paper, make a mental note, and I'm going to see how you do. Now, here's the question. If exercise accrues benefits, if they do, to what system is it proportionally awarded? How much of 100 percentage points go to the musculoskeletal system? How much on a proportional basis goes to the cardiovascular system? How much on a proportional basis goes to the neurological system? The neurological system, the cardiovascular system, the musculoskeletal system. So you might have 10-10-80, you might have 80-10-10, you might have 10-80-10, whatever. Write it down. Write it down so you can see the numbers. How much of the 100% that benefit comes from exercise is attributed to musculoskeletal? How much is attributed to cardiovascular? And how much is attributed to the neurological system? Now write them down and add them up, and it should come to 100. Okay, here's the answer. 15% only of the total benefit goes to the musculoskeletal system. 15% of the total benefit goes to the cardiovascular system. So it's good for your musculoskeletal system, and it's good for your cardiovascular system. But how many of you, let's have a show of hands. I know we've got one here in the front row. How many of you got more than 50% for this nervous system? How many of you got more than 60%? Was this a surprise to you? It's amazing. It's the brain. It's all about the brain. I love it. You've got to buy this book, or you've got to go to your public library and you've got to order it. You've got to go to the public library and you've got to order this book and you've got to read it. And it's really a fun book to read. It's called Brain Rules by this crazy-looking guy called John Medina. And you've got to go to the library and you've got to get this book, or you've got to order it online. You've got to have this book and you've got to read it. You've got to read it. It's essential reading. And rule number 1, exercise. These are brain rules. Rule number 1, exercise. He's got a number of other interesting things to talk about. I could spend a whole hour and a half discussing his book, but you're going to read it. And you're going to learn about the other rules. But rule number 1 for brain rules, exercise. So you've got to get this book. And rule number 1, Colby, exercise. So, who's heard about the runner's high? Put your hand up if you've heard of runner's high. We have a neighbor lady who goes into a steep depression unless she does a marathon every 3 days. That's a little excessive. But what happens in the runner's high? Any idea what happens when the runner gets high? Endorphins, thank you. Anything else? Anything else? It's a natural high, correct. But the molecules are endorphins for sure. And there's another one. Adrenaline for sure, but it's a short-lived thing and it comes back. Dopamine. Endocannabinoids. Endocannabinoids. Who would have known that? That's why I talked to you about the marijuana plant. That's why I told you that we are walking cannabis. We are cannabinoids. We have the same molecules in our body that the plant cannabis has. And when you run or exercise, you pump up your endocannabinoids and your endorphins. And endorphin is short for end morphines. So we have an internal morphine system. You don't have to take outside morphine. You have an internal morphine, and it's pumped by exercise. And we have an endocannabinoid system, which is one of the healing molecular systems. Thank you for that. And you pump it up when you exercise. Now, here's the point about it. You don't have to be like our neighbor and run a marathon every 3 days. Any exercise, repeat, any exercise. Brain rule number 1, any exercise pumps it up. And these are molecules that go to your brain. 2-minute break. Where do we start? The first thing about starting has got to do with that old CBT moment. It's that decision to exercise. I will exercise or I will procrastinate and do it another day. So that's the first thing. Now, equally important is to set realistic expectations. One of the biggest reasons we stop exercising is that we disappoint our expectations. Now, we all have an innate desire to overestimate our ability to do things. We all do that. So you have to actually now put yourself, slow down. We're going to slow you right down in terms of your expectations. Right down. We're going to take your expectations almost off the plan. Because if you don't meet your expectation, you will not exercise. A few years ago, decided I was going to ride my bicycle from Malawi to Cape Town. It's 4,800 kilometers, and I did it. It took me 6 weeks to do it on my bicycle. I went from Malawi, I went through Zambia, went to Botswana, where I was met by some buffalo on the roadside. We went to Namibia and went all the way to Cape Town through South Africa. So you've got to make up your mind, but don't overdo it. My wife thought I was crazy, but I did set high realistic expectations. But don't do it. That's what I was told. Everybody told me, don't do it, Bill. Don't do it. You're crazy. They were right. I was crazy. So expectations for exercise. There's untold research evidence. We don't have to do this research again. It's done. And outcome expectations are predictors of exercise behavior. Outcome expectations are predictors of exercise behavior. So if you put a goal that's too high and can't make it, you won't succeed. Now, this is really interesting. I was amazed when I started preparing these talks 18 months ago and up to this moment. I was amazed when I discovered this graded exercise therapy. They call it GET. Graded exercise therapy. In 2007, this philosophy was adopted for chronic fatigue syndrome, to see if it would help chronic fatigue syndrome patients. They then learned that it was actually quite good for everybody, especially for chronic pain patients. And there's now quite a lot of literature on graded exercise therapy in chronic pain patients. So let's look at what we mean by graded exercise therapy. In terms of the biopsychosocial theory instead of a medical theory, the goal is to reduce disability through reducing pain-related fear and other attributions. The focus is on reducing disability and not pain. It's not about ignoring pain, but it's about not allowing pain to restrict your life and attaching different meaning to pain after exposure. It's a bit complex, but there it is. So here it is. This is your graded exercise therapy program. Step 1 is to stabilize your routine. Sitting in front of you is this form. This is where you start.
Okay, thank you.
Now here's step 2. There's not one of you in the room who can't do this. It's doing regular stretches, and it doesn't have to be much. This is a few little illustrations. I wish we were all the age of this young woman who's doing all these wonderful stretches, but we're not. The lady who at age 58 had a massive stroke. And as she was recovering from her stroke, her doctor said, "You've got to walk every day." And as she went walking on the road every day, she saw people running. She wondered, what are they doing? Running. So she said, I better start running. Anyway, that lady at age 56 completed the Boston Marathon when she was 80. Now, we don't expect you to go to the Boston Marathon. They've done studies at the workplace where they've taken people who don't exercise regularly and they've alternated them between sitting during their work or standing 6 hours a day. And the workstation is lifted up here. And you stand. You don't do any exercise other than standing. And after 6 weeks, there's significant, measurable improvement from just standing.
Okay.
So next week, we'll have a review of the whole course, plus we'll talk about emotional trauma, we'll talk about measurement, and there'll be some questionnaires which we'll compare to the ones you filled out when you first started. Thank you all. See you next.
Your conference is now over. Goodbye.